Okay, so good afternoon, everyone, and welcome to the webinar series organized by Therapeutic and Diagnostic Systems and Technology Technical Committee of EMBS. And thank you so much for taking the time to join us. My name is Paola Saccomandi. I am the chair of the Therapeutic and Diagnostic Systems and Technology Technical Committee, and I'll be your host for today's session. I'm very delighted to welcome today Max Haberbush. He will present his research activities in the field of remote monitoring in heart failure, emerging technologies, and the future of implantable sensing. Um, Dr. Max Haberbush is a biomedical engineer. He is a postdoctoral associate at the Center of Medical Physics and Biomedical Engineering of the Medical University of Vienna, where he is a principal investigator. His research focuses on device-based therapies for cardiovascular disease, with a particular emphasis on heart failure. His team develops implantable and remote monitoring systems using a combination of in vivo experimentation, computational modeling, and AI-driven signal analysis. He currently leads the nationally funded CardioMEMS and VaguSpec projects and is a very active member, this I can I know very well, of several biomedical engineering societies, including EMBS and European Society for Artificial Organs. I would like also to add that many of the things that you see online regarding our TC, it happens thanks to Max's work because he's the webmaster of our technical community, and I really want to thank him for all the work, all the time spent with me trying to make our website much better as it is today. So thank you, Max.
Very welcome. Yeah.
Thank you for being with us today. Before we dive in, just a quick some notes. So this webinar will run for 60 minutes. The session is recorded and you will be able to see the recording on the YouTube channel of EMBS. At the end of the speech, we will have the Q&A session and you can directly ask questions to Max. So we are ready to start. I leave the floor to you, Max. Thank you very much.
Thank you so much, Paola, for the kind words. And I'm super happy to help with all the webmaster activities and the TC, of course. I'm going to share my screen. And you tell me if you see my title slide. Yeah, you can see my title slide.
Yes.
Okay. Yeah, thank you so much for the opportunity that I can share today our activities in the field of cardiac monitoring to improve heart failure therapy. I would like to start off with a brief overview of what you're going to see in this talk today. We'll start with some basics, namely understanding heart failure and how it's currently treated, just to frame the clinical context of things. Then we'll look at why remote monitoring has become such a promising tool and where the field stands right now. And from there, I walk you through some of the latest technologies shaping the space and share a few highlights from our own research, from telemonitoring systems over circulatory assist device monitoring to left ventricular sensing and analytics. And finally, we'll wrap up with a short summary and a look ahead at what's next for heart failure care. So what is heart failure? A standard definition would be the failure of the heart to pump blood under normal cardiac pressures at a rate that meets the requirements of metabolizing tissues. And when we look at left-sided heart failure, we can distinguish two main types based on ejection fraction. Ejection fraction is the percentage of blood pumped out of the heart's left ventricle within each heartbeat. And if this fraction is below 40%, we call that heart failure with reduced ejection fraction, which is typically characterized by this weakened myocardium. And if this fraction is above 50%, and additionally there's hemodynamic evidence of diastolic dysfunction, we call that heart failure with preserved ejection fraction, which is characterized by this very much thickened myocardium. And that's important because for these two different types, there are different approaches to therapy and also to monitoring. If we now look at some more numbers, around 24 to 47% of all the heart failure cases belong to the group of heart failure with preserved ejection fraction, and around 39 to 49% belong to the group of heart failure with reduced ejection fraction. And there's a group in between that's neither the one nor the other that accounts for around 14 to 17%. Currently, more than 56 million people are affected, and those numbers are ever rising. We expect to see more than 64 million patients worldwide by 2023. And it's really a disease of the West. So if we look at the global prevalence, we see that Western countries reach prevalence numbers as high as 3.9%, for instance, in Canada. But what we also see in the last couple of years is that the BRICS countries, such as Brazil, India, China, you name it, are really catching up. How is heart failure treated in very early stages? Usually, medical intervention is indicated, consisting of antihypertensive drugs, beta blockers, and diuretics. And as the disease progresses, more and more device-based therapies are indicated. Here's just a couple of upcoming devices, including implantable hemodynamic monitors, left atrial decompression devices, but also neuromodulation devices such as vagus nerve stimulators. And there are also very well-established devices out there since a couple of years or even decades, like the implantable cardioverter defibrillators or cardiac contractility modulation devices. And last but not least, a thing which we are very actively working on in our group is left ventricular assist devices. However, even with optimal therapy, heart failure remains progressive, underscoring the need for proactive and continuous monitoring. And to underline that, I want to give you some numbers. Heart failure today represents an enormous global burden, about 284 billion US dollars annually. And nearly three-quarters of these direct costs are driven by hospitalizations and readmissions due to lack of proper monitoring solutions. And after discharge, over 60% of patients are readmitted within just 1 year. And in the US alone, this translates to almost 20 billion US dollars spent every year on heart failure hospitalizations. So even with optimal medical therapy, heart failure remains a progressive condition, which highlights why proactive and continuous monitoring is so crucial. So here's the key idea behind remote patient monitoring by the example of left atrial pressure monitoring. If you look at the curve on the left, you can see that in heart failure, filling pressure starts to rise days or even sometimes weeks before the patients actually feel worse. And in standard care, we usually only notice that once symptoms show up, and by that point, it's often too late to avoid hospitalizations. And with continuous pressure monitoring, we can catch that rise early and adjust therapy, for instance, by increasing diuretic medication early and before congestion develops. The lower graph shows exactly that. By keeping the left atrial pressure within a stable range, we can prevent the downward spiral toward decompensation. And so the whole concept shifts from reacting to symptoms to proactively keeping the patient stable. Now, on the right, you see a graph that shows this idea in real numbers using left atrial pressure as an example. You see how the left atrial pressure starts to increase days before the fluid retention happens and symptoms set in. And with continuous monitoring, we can keep the pressure in that stable lower range, preventing congestion before it even starts. So to bring it all together, even though these continuous pressure or impedance readings are incredibly powerful, the numbers alone don't change the outcomes of this intervention. They only make a difference when they're part of a structured care pathway that is shown here, where the data actually reaches a team that knows what to do with this data and where there's a clear process for follow-up and treatment adjustment. So that's what this diagram shows, the full loop between the patient at home and the multidisciplinary team in the clinics. And once the loop is closed, the data becomes actionable and remote monitoring turns into a real therapy. And of course, for that to work, both sides need to be digitally literate. Clinicians must be comfortable using these platforms, and patients need to be confident enough to stay engaged. That's how we move from a collecting signals only paradigm to truly improving care. So what do we improve by the remote patient monitoring? There are three main factors. One would be the overall quality for the patient. If we can identify risks faster and thereby reduce readmissions, the length of stay of these readmissions, and also improve quality of life and ultimately patient satisfaction. The other category would be cost. So as I've shown you before, alone in the US, they are spending close to 20 billion US dollars yearly for heart failure rehospitalizations. If we can establish a proper monitoring, we can really reduce this burden on healthcare systems. And last but not least, we are going to improve outcomes by that, for instance, increasing the event-free survival. So I would like to give you a brief overview of the current monitoring solutions, which are both under clinical investigations and also available on the market. They range from invasive devices such as implantable loop recorders to implantable pressure and volume sensors over wearable devices that are probably more well known, such as, the wrist worn arm watches, smartwatches, or finger worn devices. And I would like you to think of the signal fidelity of those sensors as a function of invasiveness. That means that a wearable will give you quite a low signal fidelity. And as you go more invasive and move closer to the pathological subsystem you would like to monitor, the higher the signal fidelity is going to be. And many companies and research groups are trying to climb this proximity ladder, as I would like to call it. And two very popular devices that are currently in clinical use are Cordella by Endotronix and CardioMEMS by Abbott, which are implanted into the pulmonary artery. And there they are able to measure the pulmonary artery pressure, which can be used as a surrogate to congestion. And two devices which are currently in clinical trials would be the FIRE-1, which is implanted into the inferior vena cava to measure volume there, and the VLAP, which is implanted into the left atrial pressure to measure left atrium to measure left atrial pressure. However, none of these technologies made it to the ventricle, and this is the pathophysiological subsystem that is failing in the heart failure patients and which we would actually like to monitor. Currently, the left ventricle is monitored hemodynamically using catheters, so the patient has to come into clinics, into a catheter lab, and catheter is inserted through a large artery, advanced through the aorta, and then eventually placed in the left ventricle, where pressures and volumes can be measured. And the use of it is very multifaceted, but mainly it's used for heart failure diagnosis and therapy, and also for assessing mechanical circulatory support patients. What can be measured there? It's pressures and volumes over cardiac cycles. And if you look at the trajectory in the pressure and volume plane, you can get so much information out of that about the pathophysiological state and dynamics of the left ventricle. It includes closing and opening events of mitral and aortic valves, the stroke volume, so basically the amount of blood ejected during cardiac cycle, but also things like filling pressure and filling volumes, and even more importantly, the state of contractility of the heart as determined by the end systolic pressure volume relationship, where you can determine your Emax from. How does it look now? Such a PV loop, characteristic P loop in a healthy individual as compared to acute heart failure with reduced ejection fraction and the chronic heart failure with reduced ejection fraction. You can see a strong shift of the filling volume and pressures, and also a reduction in the stroke volume, so the amount of blood ejected in a cardiac cycle, and also changes in the contractility, strong decrease in contractility with progress of the heart failure. So if we can monitor that continuously in those patients, we can really get a clear picture of the disease progress and intervene early. So now I would like to dive in a couple of studies that have been performed in the last 8 years in our group, starting with a little bit older work, which is non-invasive, like the telemonitoring of circulatory assist device patients done by my dear colleague, Dr. Thomas Schlögelhofer, then HeartMate 3 circulatory assist device monitoring, also performed by my colleague Thomas Schlögelhofer. And then we go a little bit more invasive and to a little bit closer to the present time. I will talk about our studies regarding cardiac contractility assessment using electrical impedance spectroscopy, then the development of a epicardial fiber break rating sensor to monitor the left ventricle, and at the very end, I'm going to talk about currently ongoing work on epicardial microelectromechanical system sensors for heart failure monitoring. So let's start off with the telemonitoring. And back when my colleague Thomas Schlögelhofer was still an aspiring ventricular assist device coordinator at the Vienna General Hospital, he realized that after patients went home with their assist device, the real challenge wasn't the technology, it was always staying connected with them. So he came up with a structured way to check in by phone. Every 2 weeks, the VET coordinators would call patients and go through a quick guided checklist. So not just how are you, but structured questions about pump parameters, symptoms and medication and so on. And from those calls alone, each patient could be classified into one of 5 levels of severity, from completely stable to needing urgent care. And that worked remarkably well. The readmission length of stay dropped by about 15 days, and the survival of these patients improved by more than 30% in the first 2 years after the first admission. So that only happened through the structured conversation. And that's a great reminder that telehealth doesn't have to start with apps or implants. It starts with the structure and consistency and a bit of human connection. And building on this idea, Thomas and the team took it a step further. They started empowering patients to monitor some of these parameters themselves, especially their anticoagulation, which is super important for circulatory assist device patients. By using simple NR home testing devices, those patients could check their values daily instead of just a few times a week. And that higher frequency led to much better control. And as you can see here, it translates directly into fewer neurological events and better outcomes. So this was really the next evolution, moving from structured phone follow-up to self-management and early digital monitoring. Now, let's look at the Snoopy project. And the motivation for this project was that patients with LVAD devices, so circulatory assist devices, needs to be closely monitored to optimize the outcomes. You can see that clearly here. Optimized patients have significantly higher event-free survival and much lower rehospitalization rates compared to those who aren't optimized. And to achieve that, we typically rely on echocardiography or right heart catheter-guided RAM testing, which are both excellent but very time-consuming and unfortunately also invasive methods. And that's why there's growing interest in using the LVAD itself to monitor and to understand heart pump interactions and guide speed optimization in a more continuous and less invasive way. So the HeartMate 3 device is currently the most widely used left ventricular assist device system on the market. But when it comes to physiological monitoring, it has a major limitation, namely the internal controller only stores a few seconds of data and at a relatively low sampling rate. And this means that we usually only see a single average parameter, the so-called pulse index, which you can see here on the display. And that's rather than the underlying beat-to-beat flow dynamics that actually drive it. And on the left, you can see why this is a problem. The pump's flow depends on the pressure difference between the aorta and the left ventricle, which is that AOP minus LVP here. And during each cardiac cycle, this operating point moves up and down along the pump's pressure flow curve. And the amplitude of this movement determines how pulsatile the flow is. In other words, the pulse index that we just mentioned before. However, many very different physiological situations can produce the very same pulse index value. For instance, a low PI could indicate low preload and suction, or it could simply reflect poor left ventricular contractility or arrhythmia. Without continuous waveform data, the controller can't distinguish between these conditions. And that's why the group around Thomas developed a new non-invasive monitoring tool called HeartMate 3 Snoopy, which records the pump signals continuously and at a high resolution. And the goal was to characterize how the HeartMate 3 responds to control changes in ventricular loading and to use those patterns to better interpret PI events in real time. So here's how the system looks like. You got the pump controller of the HeartMate 3 device, and they developed a pickup coil that can be wrapped around the data line of the HeartMate 3 controller. And by that, they can really monitor the data flow within this data line. And on the right, you can see the entire system consisting of a battery pack, a microcontroller, and the SD card, with which they can monitor 21 days continuously and in high resolution the pump data. So with this system, they came up with an in vivo study, first enrolling 24 patients into a short-term cohort, which underwent echocardiographic speed ramp testing and Valsalva maneuvers, collecting all this data. And that allowed to come up and develop classifiers that then were evaluated in a long-term cohort of 60 patients. So the parameters they could monitor this way included the average HeartMate 3 pump speed, then the mean, minimum, and maximum of the pump flows and the HeartMate 3 motor current. Of course, the pulsatility index, the overall current uptake, and the HeartMate 3 rotor's radial center displacement and the variations around it. And they could record with an error-free data rate of more than 90% as confirmed by CRC checksums. And then they looked at the collinearities between the measured or estimated pump parameters and clinical parameters. And interestingly, there was a strong correlation, especially between pump parameters and the left ventricular end-diastolic diameter and left ventricular end-systolic diameter as derived through ultrasound measurements. Then they used Valsalva maneuver as a control physiological stress test to probe how the HeartMate 3 device responds to rapid reversible changes in preload. And as you know, the Valsalva maneuver transiently increases the intrathoracic pressure and reduces the venous return, allowing us to simulate the conditions that can trigger suction or loss of pulsatility in those patients. So here they analyze PI events defined as moments when per second PI differs from the 15-second average by more than 45%. And now here in the three panels on the right, we see distinct PI response phenotypes. In panel A, for instance, we see a simple PI undershoot. That means flow and PI drop slightly during the maneuver, but without any suction event occurring. And those patients typically need no adjustment in therapy or speed. In panel B, we see a PI overshoot due to suction occurring, and the pump briefly overperforms as the ventricle collapses. And this can often be managed by reducing diuretics and pump speed. Finally, panel C shows a combined overshoot and undershoot, reflecting both suction and low preload going on. And here, both diuretics and speed adjustments are usually indicated. So by categorizing these Valsalva-provoked PI responses, we can start to integrate PI changes physiologically rather than treating them as isolated numbers. And in other words, this provides a non-invasive way to phenotype hemodynamic states and guide individualized left ventricular assist device therapy. With that, I would like to move on to the more invasive approaches, and which are also happening currently in our lab. The first would be left ventricular monitoring using electrical impedance spectroscopy. So the idea is to repurpose the leads of implantable cardioverter defibrillator devices to perform a measurement rather to only stimulate. And the fundamental concept is that the myocardium's electrical properties change both acutely as the heart contracts and relaxes with each beat, but also chronically as the tissue remodels and stiffens over time. And These changes reflect shifts in tissue volume, blood contact, and also extracellular composition, which together influence the measured impedance. And we are using a 4-electrode electrical impedance spectroscopy setup. A small alternating current is injected through the outer electrodes, and the resulting voltage is measured across the inner pair. And just using Ohm's law, the ratio of voltage to current gives the complex impedance of the tissues. By sweeping the excitation frequency across a defined range, so in our case between 100 Hertz and 1 megahertz, we can separate the resistive and capacitive components, which reflect ionic pathways, cell membranes, and extracellular composition. In other words, the ES lets us to probe both the electrical but also structural properties of the myocardium, capturing changes due to contractility and long-term remodeling. Together with our colleagues at the Electronic and Electrical Engineering Department at UCL, we came up with a portable electrical impedance spectroscopy device, which is here illustrated or shown a photo of it with also conventional pacing leads used for left ventricular pacing attached to it. And we evaluated this system in a series of in vivo experiments in swine. So that up there are atrial pacing leads, so don't confuse them for the actual electrical impedance spectroscopy leads. Down there, we got a PV catheter inserted through the myocardium into the left ventricle to monitor pressure and volume. And then we got anterior and posterior electrical impedance spectroscopy leads to perform the measurement. And we also carried out the same kind of measurements in ex vivo isolated hearts that are working rabbit hearts, just for the reason that we can control the pre and afterload conditions way better in this kind of setup. And then we run the following experiment. We start with a baseline measurement followed by repeated dobutamine injections. Dobutamine is a pharmacological agent that allows us to increase the contractility. And now we are looking at the preliminary results of that. Here are the hemodynamic measurements performed in a swine, including the electrocardiogram, left ventricular pressure and left ventricular volume, and the aortic pressure. And at this point, we injected dobutamine, and this leads to this strong increase of cardiac contractility and consequently to an increase in the left ventricular pressure and also deviations in other hemodynamic parameters. And now we were interested how does the impedance spectra change from a baseline condition to post-dobutamine injection condition, which is reflective of increased cardiac contractility. And here you see qualitative results that we collected in 2 swine. You see in both swine that there's a strong decrease, or strong is maybe exaggregated, but a decrease in the in the real impedance over the entire frequency band compared between baseline to 5 minutes and 15 minutes after the dobutamine injection. And we hypothesized that the reason for that is that dobutamine leads, of course, to a higher blood content that is passing through the left ventricle, leading to an increase in the conductance, and also there's an increase in perfusion of the myocardial tissue, again leading to an increase in the conductance and vice versa, reduction in the impedance trace. And after that, we were interested if we could maybe even measure intra-beat dynamics using the electrical impedance spectroscopy. So we now record those spectra 50 times a second. Here you can see a result in an isolated rabbit heart in which we can clearly see that the real impedance follows the left ventricular pressure, which somehow makes sense because when the heart ejects, the blood volume is decreasing in the ventricle, leading to decrease in conductance and consequently to an increase of the impedance. So I would like to briefly talk about an implantable fiber Bragg grading sensor for cardiac monitoring that we developed together with our colleagues at the Biorobotics Institute at SSSA Pisa. The project was focusing on developing this kind of sensor using a fiber Bragg grading technology. And the idea was to use an optical fiber embedded in a small elastic housing that can detect even subtle deformations of the heart wall. And these tiny strain changes shift the reflected wavelength of the fiber, which can then translate into pressure and motion signals. To make sense of these complex signals, we used neural networks that can extract features like heart rate or ventricular dynamics in real time. And you can see the concept on the left, the sensor mounted on the ventricular surface, and on the right, an isolated working heart experiment showing the sensor fixed directly on the left ventricle. And this setup allowed us to capture high fidelity mechanical signals synchronized with the pressure recordings. Here you can see some of the results from the isolated heart recordings. We compared a simple dynamic thresholding algorithm to our neural network approach for extracting heart rate from the Bragg sensor. And the neural network performed much better, reducing the mean absolute error from roughly 11 beats per minute to just over 3 beats per minute. What's even more interesting is that the sensor signal was detailed enough to clearly distinguish systole from diastole, which means we can track not only the heart rate, but also ventricular dynamics over time. So for most recordings, the heart rate error stayed below 2 beats per minute, essentially within clinical precision. So this combination of optical sensing and machine learning gives us a very stable, high-fidelity readout of the heart's mechanical activity, even in a beating, moving organ. And now I'm moving to a currently ongoing project that I'm leading in our lab, which is about the development of an epicardial microelectromechanical system sensor that allows to measure left ventricular function from the outside of the ventricle. So as I mentioned before, usually those sensors are implanted into a vessel or a cardiac cavity. With our technology, we try to do that from the epicardiac surface. We therefore developed a electromechanical sensor array. So in a linear arrangement, you see that in D, for instance, which measures local ventricular contraction forces. And by using a machine learning model, we try to translate those local ventricular contraction forces into left ventricular function markers of interest, including the left ventricular end diastolic and end systolic pressures, but also surrogate markers of cardiac contractility, including the maximum and minimum rates of change of the left ventricular pressure, and ultimately the Emax. The way we are doing that is by using a random forest regressor. So we segment our sensor readings, perform a feature extraction, such as the minimum and maximum rates of change of the sensor signals, and also the peak-to-peak amplitude. And then we train our random forest regressor using the standard split of 8 to 1 to 1 for training, test, and validation sets, and to train our regressor to predict our cardiac function markers. What's not shown here is also a recurrent neural network that we developed that can not only predict those markers on a beat-to-beat basis, but really track the real-time or the instantaneous left ventricular pressure. We are evaluating those sensors in vivo acute experiments in sheep and swine, and also in ex vivo isolated working heart experiments in sheep hearts. And the setup is the following, that we got our heart with a left ventricular assist device, and we perform again pressure volume catheter measurement with the gold standard Miller catheter, so we can compare our sensor readings to a validated device. And again, we perform our dobutamine stress test, injecting dobutamine to increase cardiac contractility to challenge the heart. And now I'm coming to the preliminary results. In panel A, you can see the left ventricular pressure trace of a single heartbeat as we recorded in an isolated sheep heart with the left ventricular assist device. And the solid blue line is the gold standard reading from the Miller catheter, and the dashed lines represent our model predictions or our sensor readings for different levels of noise injected into our sensor signals. And you can already appreciate that our system very well tracks the the intraventricular pressure with coefficients of determinations well above 0.95 and also with root mean squared errors well below 2 millimeters quecksilver and bias below 0.5 millimeters quecksilver. We then looked not only at the instantaneous pressure, but rather at the left ventricular markers of interest over a couple of hundreds or even thousand heartbeats. And in E, you can see an example, again, dobutamine stress test at around heartbeat 100. So horizontal axis are heartbeats. At around heartbeat 100, we injected dobutamine, leading to this steep increase in contractility and therefore end-systolic pressure. And the blue markers represent the catheter readings from the gold standard Miller catheter, and the orange markers represent our sensor readings. So you can see again that our sensor tracks very well in both conditions with increasing and decreasing contractility here below the gold standard measurements. And we then performed a systematic analysis over all our experiments with multiple dobutamine stress tests and performed a blunt Altman analysis showing that we can measure our left ventricular end systolic pressure and end diastolic pressure, for instance, with accuracies or with a bias well below 1 millimeters mercury. And overall, we get coefficients of determinations above 0.88 across all markers and conditions. And also, small biocompatibility testing has been conducted by our colleagues at SSSA Pisa, where they implanted this sensor, non-functionalized, like just a dummy, into a mini pig for 120 days and then compared the tissue response to a mini pig without the sensor implanted. And then there we can see there is no significant difference in the collagen deposition between the swine with the sensor and the swine without the sensor, giving us some confidence that our sensor is biocompatible. So to wrap things up, if there's one key message I'd like you to take away is that heart failure is not a static condition. Even with the best therapy, the patient's hemodynamics evolve day by day and in some cases even hour by hour. And that's why continuous and high fidelity monitoring really matters. It lets us see what traditional snapshots like echo or in the cath lab cannot do. But collecting data alone doesn't help the patients. The value really lies in the integration, linking those sensor analytics to care team, and so that every data point can drive a real clinical decision. And from left ventricular assist device telemonitoring to our ongoing work on epicardial MEMS and impedance sensing, the direction is quite clear. We are trying to move from simply observing patients to understanding and anticipating their physiology. Looking ahead, our next steps are all about making this vision real, so bringing it to the patient. Right now, we are about to start testing our sensor in long-term animal models to make sure they are stable, safe, and reliable. And the next step is to bring everything together, the sensors, the analytics, the telemonitoring platforms, so the data can actually inform care, not just sit on a dashboard. And from there, we'll move toward clinical feasibility studies, so first in human trials, where we can finally test how the system can help to guide therapy early and more precisely. The ultimate goal is closed loop heart failure management, where monitoring becomes understanding and that in turn becomes action. Because in the end, it's not about collecting more data, it's about giving patients more time and giving clinicians more clarity. With that, at the end of my presentation, I would like to thank our amazing cardiovascular dynamics and artificial organs group, and of course also all our collaborators at the Center for Biomedical Research and Translational Surgery, the Fraunhofer IMM, the Biorobotics Institute at Santa Ana Pisa, and also the guys at the Electronical and Electrical Engineering Department at UCL. And last but not least, of course, also all the funding agencies which make this kind of work happen. Thank you very much.
Thank you so much, Max. It was really, really, really interesting. Yeah, I would like now to open the Q&A session, and yeah. I received the comments from the audience. Yes? Oh, yeah, already many questions. Yes. Okay. Yeah, we have a question from Professor Pani. Hi, Danilo.
Hi Paola,
Hi.
everybody, can you
Please.
hear me?
Yes,
Yes,
yes.
yes, we can.
Okay. So thank you for the very nice presentation, very clear. I have a question about the implantable devices for monitoring. So, in your opinion, so the problem in this case is that every implantable device has a problem of a reaction of the creation of fibrotic tissue, the
Mm.
formation of scars, etc. when it's attached to the human tissues and then also to the epicardium. So I would like to know if, based on your experience, you really envision an application of this kind of monitoring system, consider that it's not safety critical in the sense of an intervention during a specific condition like an arrhythmia or an attack, but it's just for monitoring purposes, or if you think that it is still more like an academic research and the way is far along.
Now, it's really a good question, and I think there are two facets to it. The one thing is like the formation of connective tissue, like, basically scar tissue at the place where you implant your sensor. And this obviously introduces a challenge because, on the one hand, the mechanical properties, the biomechanical properties at this place are going to change, making it harder to make an inference using, for instance, our MEMS pressure sensor. But also the bioelectric properties are going to change since, connective tissue has way different electric properties than a myocardial tissue. So this is a real issue we do not know how to tackle yet for the MEMS pressure sensor. However, we did some in silico studies, so basically finite element simulations, where we looked at the forces that the sensor is exposed to for different scenarios of tissue decomposition, meaning for a healthy myocardium, for fibrotic myocardium, and also once connective tissue hull has formed. And we can see that there's not too much changes in the pressure that or in the forces that the sensor is exposed to. So we hope that our sensor can remain stable over time. And the second facet is, of course, a regulatory one and a patient safety one. And we are in a very early stage here. So we are maybe at technology readiness level of 4 to 5. I recently became a fellow in a spin-off fellowship of a national funding agency, and the goal is here to translate the sensor within 18 months into a first-in-human trial, which is quite challenging, obviously. So we are currently trying to understand what kind of data we have to collect and in which way to present this to the named bodies in Austria, so we can proceed into a first-in-human trial. But we had a lot of discussions with colleagues who are very interested in using this type of sensor, not for remote patient monitoring, but rather for measuring pressures within in vivo experiments, like acute in vivo experiments in sheep and swine, but also in smaller animals. And the reason for that is, for instance, if you implant left ventricular assist device, you're changing very much the pressure and flow conditions around the inflow cannula, for instance, of this device. So the catheter positioning is quite challenging to get a proper reading. So the idea would be to have a more reliable reading if we can put the sensor on the surface of a vessel or a heart chamber and measure from there. So I hope I answered your questions by that.
Yeah, thank you.
You're welcome.
Thank you, Danilo. Any other question? I saw. Yes. Yes. Thanos, please.
Hi,
Hi.
you're hearing me?
Yes.
Thank you very much for the presentation. We're 40 people here attending the
Oh, wow.
presentation at the University of Thessaly. Okay. Well, my question is regarding the autonomy of such devices. I believe that most of them are, in fact, research prototypes, but in the case that these are already used, I can understand from the one hand that wearable devices are presenting more autonomy and are more easily to be used, but when accuracy is required, then of course implantable devices are preferred. But what is my question is about the autonomy of such devices, like the implantable ones, and the cost of them, and of course what is happening in the case that the autonomy is low, and how do we take care of it?
Thank you very much for this excellent question. I would like to ask you to be a little bit more clear what you mean by autonomy. I'm not sure if I understand that entirely.
I mean, do the devices need a steady power supply, or
Ah,
or
yeah.
are they working with, they're operating with a battery, so
Yeah, and I
okay.
now I understand. Yeah. So maybe to go back to the one fact that you mentioned about the signal fidelity, so to say, or accuracy of the measurements, and when you compare a wearable to implantable sensor device, that's perfectly clear. I just wanted to add that there is also patient compliance, and I think we see this in patients with the CardioMEMS pressure monitor, where they need to actually power their sensor inductively by placing a reader above their chest. They are not very compliant. So in the first weeks and months, they are doing it daily, but as time moves on, they are doing it maybe every other week. So you really lose there a lot of data and opportunities for the clinicians to intervene. So that's the real strength, I think, of an implantable device, because the compliance is given automatically because it's implanted and it transmits data. About the autonomy, obviously our MEMS sensor, for instance, needs to be permanently powered using a cable that currently comes outside the body through a port, a cable port. And that's the reason why we initially target the left ventricular assist device population, because those patients already need to have a drive line that leads out of the body to power this device. And we are going to use the energy that is provided to the LVAD, or part of the energy, to drive our sensor. However, we are currently also working with guys from formerly UCL, but now University of Oxford, to come up with ideas to harvest energy from the movement of the heart, so we can power the sensor from inside, so to say. So we do not need a cable port outside. We do not need to replace batteries, etc., and can have a wireless RF link to stream data outside.
I have one more question.
Yes, please.
Okay, so you mentioned something about machine learning, and I didn't get it. Is it about cloud computing machine learning, and you're developing the models, or is it about edge machine learning that is occurring at where the data are generated?
Excellent question. Yeah. Now we are really believing in that the future is edge. So the algorithms that we develop are very lightweight. So you've seen the random forest regressor, for instance. It can run on a microcontroller, but also our larger deep neuronal networks, so our recurrent neural networks, can operate on microcontrollers with quite low power consumption. Yeah.
Thank you very much.
You're welcome.
Yeah, thank you for the excellent questions and answers and the discussion that came from this. I also have a question, actually.
Sure.
Would you like to comment on pros and cons of the last two technologies you mentioned? So the MEMS-based sensor and the FBG one.
Mm-hmm. Very interesting. So in essence, they are measuring two different things, right? So the FPG sensor measures a strain of the myocardium, whereas the MEMS sensor is going to measure pressure. So basically, the idea would be to use a FPG sensor for assessing the stiffness of the myocardium. So this is something more for the long-term fibrotic changes occurring during chronic heart failure, remodeling of the cardiac tissue. Whereas the MEMS sensor really shines when it gets more to the dynamic pressure loading and unloading of the left ventricle. And another thing is I'm not an expert in, fiber grading technology. So this is maybe something a colleague from the SSS APs I could comment on, but I'm not aware that those FPG interrogators are yet implantable. So so I think that's a big limitation because thinking of our interrogator that we use, that's quite a bulky device. So I don't think that patients would like to carry this thing around and they cannot. Yeah. So I think the future really would be the MEMS sensor for now, at least, unless there's developments in the FPG field to miniaturize things and make that implantable.
Yeah, this is the dream of everyone working with FBG sensors. I am one of them, so but
Okay.
yeah, I think the way is still quite long for
Yeah.
the implantable interrogators. Yeah. Portable, yeah, there are good advancement, but implantable, we'll
Yeah.
see
Way to
in
go. Yeah.
some years. Yeah. Yes, thank you, Max. Any other question? Any other curiosities from the audience? So today you had a very large audience.
Unexpected, yeah.
Online, many people actually, but also, yeah, they were a group, so
Yeah, thanks,
very
Thanos, for bringing 40 people.
yeah. No, yeah, the topic is really amazing. Yeah. Yeah, congratulations
Thank you so much.
for all your work. Yes.
Yeah, and thanks again for organizing this wonderful seminar series.
Yeah. I've learned a lot. I've learned a lot from all the speakers, so all of you. I think it's a precious yeah, gifts that we give to the community, and not just to therapeutic and diagnostic systems and technology community, but also to all the other communities. In fact, I delivered the message, but you know it, to all the other committees, because I think that so it is a interdisciplinary work. So
Totally agree.
yeah. Okay, I think that there are no more questions. We are perfectly on time. Max, would you like to add something or we leave you go?
No, I just want to thank everybody for joining, especially my colleagues that I invited and that took the time after the working day to join me in this session. I really appreciate it. And thanks again, Paola, for organizing this webinar series. Yeah.
My pleasure. Thank you, Max, again, and thanks to all the attendees today, friends, colleagues, and all the attendees, really. Thank you, Max. Again, I wish you a wonderful day for you. You have a full day ahead, afternoon for the others, and evening. And yeah,
Thank you.
stay in
Bye-bye.
touch. Bye bye. Thank you. Bye bye.
Take care.
Congratulations, Max.
Bye.
Bye bye.